जैसे टीपू ने कहा मैं इसको यही कह रहा था कि यार सर्दियों का मौसम है, किसी ने अखरोट पेश किया, किसी ने बादाम, किसी ने पिस्ते, किसी ने काजू, तो उसी का एक मिक्स नट प्लेट जो है मेरे पास है कि फोकस की चीज़ें भी हैं, स्ट्रेस की भी हैं, कॉम्प्लिकेशंस ऑफ एमआई भी हैं, तो वहाँ से शुरू करते हैं। दिस इज़ केस बेस्ड। सो फर्स्ट हम क्यों कर रहे हैं, ये सबको पता है कि इट्स वेरी यूजफुल मॉडलिटी फॉर द डायग्नोसिस एंड प्रोग्नोसिस ऑफ एनी कार्डियक डिजीज. It is non-invasive, less expensive, and portable and readily available. And it is mandatory in all patients with acute coronary syndrome. It should be performed by a competent person. That's most important, even before cath in most of the ACS cases. I will show you how it can change your management. Palm echo or POCUS is now available. And even वो palm echo हमारे पास पिछले 10 साल से था, but now it's very common. It should be present in every hospital, whether cardiac or non-cardiac, and at least 2-3 persons trained on it. So echo विक्रम ये पहले आया था एक कंट्रास्ट echo का, पर वो प्रूव नहीं हुआ, तो ये पहले का लिखा हुआ है, इसको हम छोड़ देते हैं. We move from case like 50-year-old man, known case of hypertension, presented to the ER with chest pain and sweating for 2 hours. ECG showed sinusitism and left bundle branch block. No prior ECG is available. This is a scenario which often we see in the ER. So what should be the next step? ठीक. So next step would be you do a focus and if you find this image that there is only a atypical septal motion, it means this is not acute coronary syndrome, and you can relax. And on the other hand, if you find these images, then it will confirm that this is the entry wall MI, and you will activate the cath lab and treat it accordingly. So focus or echo will change your diagnosis or clear your diagnosis. Next is 56-year-old lady, known hypertension and diabetes mellitus, chest pain and sweating for 30 minutes, but it was 2 hours back. And now you have the T-wave inversion in V1 to V4, and which is not an uncommon finding in a female. Troponin 2 sets are negative, and how to treat further. So you are not sure, जैसे अभी अदील ने हमें सारा कुछ पढ़ाया है, and we do a stress echo, and this is the dobutamine stress echo because we have four images here. So when you have 4 images, this is the dobutamine stress echo, and we find that these are the rest images, stress images, and hyperdynamic LV on the stress images. It means there is no significant coronary artery disease, and you can think for the alternative diagnosis. But same patient, if the stress echo result is like this is the treadmill stress echo. You have the rest image and you have there the stress image. You see the wall motion abnormality in the LED territory in all images. It means it is coronary artery disease and significant area under the risk. You do the coronary angiogram and treat it. Then you move next. 58-year-old smoker with diabetes mellitus, chest pain for 2 days, troponin positive, and ECG. ये वही ECG अदील ने शो की हुई थी. And sometime you get confused with the ST elevation, but there are certain features which suggest that this can be a pericarditis. You do the transthoracic echo, normal echo, no ball motion abnormalities that will rule out that this is ST elevation MI, and you can breathe easily. Then next case, 60-year-old lady, known case of diabetes mellitus, shifted to your hospital and she is status-post streptokinase. अभी तो सिंध में ये मसला ख़त्म हो गया है streptopost streptokinase. Everybody gets a primary PCI, but maybe other provinces में हो, और पहले हमने बहुत देखे. She remained hemodynamically stable, asymptomatic since initial event, and how to manage further. So again, the same patient, if you get this echo findings, like some wall motion abnormalities and near normal LV function, so you will be more comfortable and treat it likely. But if you find the same patient with this echo, there are extensive wall motion abnormalities and the LV function is low, this is a high risk patient and need aggressive treatment. To move to the next case, 65-year-old man, known case of hypertension and diabetes, anthroceptal MI, SK day before, coronary angiogram show the 100% left LED, echo moderate LV dysfunction, how to proceed further. So someone with this, you have to do the viability study, and again we discussed that the dopamine stress echo is a test you can do for the viability, and here you start from the baseline, then low dose dopamine infusion, and then you go to the peak heart rate. So if you see from here to here, the wall motion abnormality is improved, and here again the wall motion same is happening here. If you see, there is improvement at peak heart rate, there is deterioration, that the biphasic response suggestive of ischemia and viability, and this be peak revascularization. Then 60-year-old man, hypertension, chest pain 2 days back, ECG, sinus rhythm, QS in inferior leads with millimeter ST elevation. Coronary angiogram, 3-vessel coronary artery disease with Timothy flow in the RCA, planned for the cabbage. Chest pain with ECG changes, relook angiogram unchanged, hypotension in CCU, and urgent echo was performed. And you find this picture. And this echo clearly shows there is a development of pericardial effusion and there is signs of tamponade, so suggesting there is a free wall rupture. A 55-year-old man, a smoker, epigastric pain for 3 days back for 6 hours, treated with PPI, ECG waves in the inferior lead, presented with acute dyspnea and dizziness. Heart rate is increased, the blood pressures are low, and with examination you find a systolic murmur and urgent echo was ordered. If you find these images, that shows you that there is the thinning of the interventricular septum, inferior septum, short axis, same finding. You put the color and you see that the color is going across the septum. It means there is a VSR and need urgent surgical treatment. But same patient, if you find these images, that the coaptation of the mitral valve is not good. There is a huge MR on 2 images, and you see there is a dense and the V cutoff shape of mitral regurgitation jet. Same patient, same finding, but I could differentiate. It is the acute ischemic mitral regurgitation and needs urgent surgical intervention. Case 8. A 55-year-old lady, known case of chest pain for 4 hours, hypertension, chest pain for 4 hours, ECG 1 millimeter elevation, V1 to V4, coronary angiogram showed normal coronaries, then you perform echo. And you perform echo, and if you find these pictures, that will tell you the diagnosis, that you see this is the apex, here you see the apex, here you see the apex. So it's ballooning of the apex, so it is Takayasu or stress cardiomyopathy. Then you move to next case. 65-year-old lady, known case of hypertension, severe chest pain, upper back pain, radiating to the arms for 4 hours, ECT, non-specific changes, troponin negative. How to manage? Again, the answer is the echo. If you find this echo where the aorta is dilated and there is a flap visible here, also in the short axis you find a flap, and you see two lumens, like the true lumen, you see the color, false lumen, there is no color, and you see the measurement of the aorta, which is 57. So clear-cut diagnosis that this is dissection and treat appropriately. But if you find this picture with a similar history, you have to see the aorta. You move little bit towards the aorta and you see the whole aorta. Measurements are normal, no other findings. So this could be the you can, if the other things are okay, you can clearly rule out that there is no dissection. But if the clinical suspicion is high, and particularly if the aorta is dilated, then you have to do a transesophageal echocardiography. You move, and if you do in such cases, or you find that the aorta is dilated, there is a flap, and there is a true lumen, false lumen, and aorta is dilated. So if the aorta is dilated or clinical suspicion is high, and you don't have findings on the transthoracic echo, you have to do for TEA or CT angio. A 60-year-old man, diabetes, hypertension, osteoarthritis of knee, work as a cashier, presented in the ER with chest pain dyspnea for 4 hours. ECG shows sinus tachycardia, incomplete right middle joint block, 0.5 less stimulation in V1, V2. And when you perform an echo, and you find this picture, like the RV is dilated, and RB is dysfunctional. Here is more clearly visible dysfunction and dilated. And here you can see the McConnell sign, the hyperdynamic RB apex. And this shows that this is the pulmonary embolism. And you also realize that since the echo criteria for the pulmonary embolism developed, we have more and more pulmonary embolism where we don't suspect even an echo finding. You do the CT and you find the pulmonary embolism. So our diagnosis increased, our treatment improved. Um, then, 35-year-old man, smoker, palpitation, chest pain for 2 hours, ECG atrial fibrillation with rapid ventricular rate, high QRS voltages and 2 millimeters T depression and T-wave inversion in inferolateral leads. Synchronized cardioversion was performed, troponin borderline positive, and for the further management, echo was done. And we found that here you find that the thick septum, here you find that the anterior motion of the leaflet, this is the thick muscle wall, and this is the thick muscle wall as well. So this is a hypertrophic cardiomyopathy, and when these patients become tachycardic, they can develop the typical chest pain that mimic like this is acute coronary syndrome. Then a 55-year-old obese lady in known case of hypertension, dyspnea and chest heaviness for 3 days, tachycardic, low blood pressure, ECG of sinus tachycardia and non-specific changes. And what next is easy answer that we do the echo, and you do the echo and you find there's a large pericardial effusion and there are features of tamponade. Even you see the RA collapse, you see the RV collapse here, and these are the Doppler parameters of the tamponade. So this lady has a tamponade and need immediate care. In summary, echo is mandatory in all patients of the acute coronary syndrome. For the diagnosis of acute coronary syndrome, post-MI risk stratification, complications of the MI to be picked, and rule out other diagnoses mimic acute coronary syndrome. Thank you very much.